Welcome to Healthy Harbor. I'm Eleni Kondogli and I'm your host. I would like to introduce you to Michelle Aceto from Harbor Health Services. Michelle is the Wellness Program Manager for Harbor Health, and she's here today to talk about a very important and very sensitive subject, opioid addiction treatment, and in particular, office-based opioid addiction treatment. Welcome, Michelle.
Thank you. Thank you for having me.
Let's start actually with a little bit of background information and data that we have found it as being astounding.
Yes.
So from January 2014 through May 2015, there were 313 overdoses in Plymouth, resulting in 15 deaths. Projected opioid-related deaths climbed from 54 to 85 between 2012 and 2013. A 57% jump, an increase of from any county in the state. We had 1,019 substance abuse treatment admissions in 2014, 50% for heroin. 48 confirmed unintentional opioid overdose deaths between 2000 and 2013. In late 2014, early 2015, the Governor's Opioid Working Group made several recommendations. Most of them, if not all, point the healthcare community towards office-based opioid treatment. And also, there was a recommendation about office-based opioid treatment as well as evidence-based medicine. So, Michelle, tell us a little bit about office-based opioid treatment, and why do you think it's a more efficient way of treating the patient?
Certainly, and I would probably use the word more effective. The advantage is the patient is getting wraparound care. We're not just handing out medication. We are addressing all of the patient's needs, medication, spiritual, the dental that we have case management. They're being referred for their infectious disease issues. So when we're treating the patient, we're treating the whole patient, and that is the approach that we're taking. So they're getting whole health treatment, which is what our patient-centered medical home is trying to accomplish. So it's essentially a part of our patient-centered medical home approach.
We are using actually the term medication treatment within the office milieu. Can you tell us a little bit about the medication?
Absolutely.
What type of medication?
Certainly. So there's a couple of medications out there now that are used for opiate addictions, dependence. Certainly the long standard had been methadone for years, and along came buprenorphine years ago. It's known in the street as Suboxone. There are several brands of it now. There's Zubsolv, there's Bonavail, there's now generic Suboxone. So it's a buprenorphine combined with naloxone, which is the Narcan, which we've heard a lot about, and I can go on about that in a moment. The combination of those two drugs in the tablet is dissolved under the tongue. One of the formulations is also dissolved as a patch in the cheek. So the Narcan actually, or the naloxone, doesn't actually get absorbed unless the medication were to be abused. The medication buprenorphine is what we call a partial agonist, unlike methadone, which is a full agonist. So the buprenorphine will activate the receptor and take the person out of withdrawal, but it will not allow for the euphoria that a full agonist opiate would. So certainly it is replacement therapy for the drug that the person would be dependent on. But that person is no longer high. As a matter of fact, most of our patients let us know that they actually feel normal now. And it allows them to actually get up and function on a regular basis, on a daily basis, to go to work, go back to school, and to reconnect to their communities. The excellent advantage of this medication also is its long half-life. So it only has to be taken once a day. So the act of taking drugs over and over and over again all day long, that habit can be changed. So it's quite beneficial medication.
You're talking about a patient actually who is very actively seeking treatment. And unfortunately, what we hear in the community is a very different picture. So if you can help us understand a little bit more and a little bit better,
Certainly.
who is the patient? And in terms of seeking treatment, in terms of living a healthy life, even if they had basically the background that they did.
Certainly. I could tell you in the years that I've been doing this, in the hundreds of patients that I've treated, there's very few that have been exactly like one another. The majority of our patients in recent years have been 18 to 25-year-old kids, fresh out of high school. Recently I've had honor roll students who played high school sports and did heroin their last year of school. It's an amazing drug, opiates, what they will do in an adolescent brain. I've treated lawyers and doctors and nurses and police officers, and you sometimes would not know that someone has been using heroin standing next to you in a bank line because there has not been enough treatment out there. People will maintain themselves on the minimal amount of drug necessary, meaning heroin, to keep themselves from getting sick just so that they can go to work. And so there are all sorts of people from all sorts of walks of life out there needing treatment and needing it desperately. And that's where these office-based opiate treatment programs are really going to be very beneficial for the communities.
You're talking about pretty much, the star athlete, you're talking about the lawyer, you're talking about, the mother who is doing very well with her kids, bringing them to sports, etc. Why would anybody like that?
I don't know that anybody would actually like that, but what happens a lot of times is with these pain medications, someone might be prescribed them, someone might be on them a little bit too long. There might be underlying conditions like depression or anxiety that hadn't been addressed, and the brain will grab those drugs and use them for self-medication or whatever. There's so many different reasons why a person might become addicted or dependent to these drugs. And unfortunately, there's a tolerance that grows to these medications. A person needs more and more of the same drug, and over time, that original feeling that the drug gives you goes away. And instead of the person, what we call chasing the high, what happens is now they're chasing the sick away, because in the absence of the drug, the brain will make the person very, very, very sick. And so now they're chasing the withdrawals away, and usually using only enough in order to do that. Well, usually by that time, their drug use has escalated to the point where it's become a very expensive one. This is with the pills. So most people do end up turning over to heroin because it's a much less expensive form of the drug. Unfortunately, the tolerance to heroin grows very quick, and it's very soon they'll be using injection drug use. So it's getting into treatment quick is usually what we want to see people do before they get to the point of using heroin.
How does somebody stay in treatment?
Certainly takes commitment and a willingness to want things to change. There's a lot of fear-based and anxiety-based thought processes that our patients go through. They are in a culture of people who are telling them, no, come on, let's just go do this one more time. Let's just one more. And their brain is telling them the same thing. And it's troublesome for them to, even if they're living in this negative day in, day out, trust that it's going to be better. If they haven't experienced that, they don't know that that might be okay for 1 or 2 days, but it's going to be taken away from them. So it's a very interesting pathway. What we want to do is make sure that we're seeing our patients regularly, and what we try to do is see our patients weekly. We're phone calling them as often as possible. When they are late for appointments, we're on the call, making sure they're on the bus getting to us. We're connecting them to community service providers and case management who will go and pick them up and take them to their appointments to reduce their no-shows. We're making sure that the integrated behavioral health is seeing them as soon as possible so that they have as many coaches in their life as is a part to help support them and to get them to understand that they are still a part of a community of people who care about them. And I think that's what's the message they need to hear.
Can you tell us a little bit about support systems, and especially what kind of supports a family can provide to somebody who's going through?
Yeah. So for a lot of our patients, the family network has fallen apart for them. We see it, unfortunately, with a lot of our younger patients. Their drug use has forced them to steal, to sell things of the family's belongings, and cause some ripples because of their behaviors. And so some of their families have either turned their backs on them, and they are no longer able to connect with their families. But in other ways, some of their families are really supportive of them. And what we do try to do is try to get our families in with the patient visits, so that they see what the patient is doing and they see what the work that's going on, and so they can work together. And then sometimes we try to get them to go into family counseling. It's not always possible, but we do feel it's important that those patients have as much support as possible.
Ms. L, thank you for that. We're going to go on a brief break. And please stay tuned, and we'll be right back.
Are you putting off seeing the dentist because you can't afford it, or because you think you can't afford it? Harbor Community Health Center Plymouth can help you. We see children, adults, and seniors, and we're committed to providing high-quality dental care to everyone. If you're self-employed, if you have Mass Health, or even if you don't have any dental insurance, please give us a call to set up an appointment. You can reach us at 508-778-0300.
Welcome back to Healthy Harbor. I'm Eleni Kondogli, and I'm your host. I would like to reintroduce Ms. Aceto. We're talking about office-based opiate treatment. It's a very current subject. If you were here at the beginning of our show, we covered some very important statistics and some very telling statistics. I would like to ask Ms. L at this point about some of the work that she has done on the Cape, that it was extremely successful. Maybe she can share some of the success stories and how we're going to be replicating some of that actually here in the community in Plymouth.
Thanks. Yeah, very proud of some of the work they did on the Cape. I work with 2 other community health centers. Both programs are still up and running and doing quite well. The part of the program that I feel is most important is the support we get from the community. Having the knowledge that what we're doing is just as important to the community as it is to the patients is vital. These patients, we want to become productive members of society, and that society has to support what it is they're trying to accomplish and what we're trying to accomplish as the providers. So being able to work together is vital to their success. We had one young man who was still in high school. He was an extended student, so he stayed an extra year, and by working with us and staying in, he actually ended up being able to graduate high school, not with a GED, but with a high school diploma. And it brought tears to all of our eyes, but that kind of success, and knowing that young man, he's probably now finishing college, you know, and to know that there is a possibility for these young people to actually live normal lives and not become part of that whole culture of that's the sum total of who I am now because of that experience I had when I was a child. And knowing that the community supports them it's vital. It's absolutely vital that we all get behind these young men and women and let them know that we're here for them. So,
thank you for that. Another question is basically, is the use of medication like buprenorphine basically replacing the drugs that the person in treatment is currently under?
It's a good question, and I would have to say that we know that buprenorphine is an opiate, and so in a technical position, then certainly yes, you're taking one opiate and you're putting it in for another. But if you remember, I said that buprenorphine is a partial opiate agonist, and the drugs that they're using are full opiate agonists. So the patients are no longer getting high, but they feel normal. But one of the things that I'd like to explain to people is that we're talking about people who are misusing drugs, and their lives are sort of falling apart because of that. One of the things I like to try to share with people is that we have patients who come into our offices and they have, say, a raging infection on their foot, and we have to get that infection under control because that person could lose their limb. And that infection is probably because they have diabetes and they have not been treating their diabetes, and we have to be really careful about what it is that we address because it's so important to make sure we're taking care of the whole person. So we need to give them a medication to take care of the infection. So we give them some antibiotic, but they also need insulin. And we're not going to take their insulin away if they don't do well in their program. And we know that that's not a substitution for good eating and taking care of their stress and making sure they're exercising. However, when you're treating a whole person, you have to look at what are their limits and their gifts and their coping skills. What are their abilities to get in and actually meet that nurse and meet that doctor and take care of everything they need to take care of to be whole. And if the substitution by giving them a new medication actually gets them to come in and show up and meet those things that they need, then that's a step in the right direction, just as if a diabetic was getting the insulin to now actually improve their lifestyle habits and meet with those nurses and doctors and get healthier. So that's our approach.
Thank you for that. That's a great answer. Thank you.
You're welcome.
Can you tell us a little bit about the difference between the drug that you're describing and Vivitrol?
Certainly. So, like I said, the buprenorphine is a partial agonist opiate. That partially sits on the nerve receptor, slightly activating it so that the cravings are gone and there's no withdrawal symptoms. No activation, so no euphoria. The naltrexone is actually a blocker, so it's an antagonist. It completely blocks the nerve receptor, so there's absolutely no connection. There's no euphoria certainly whatsoever. However, there's also no allaying of cravings or withdrawal symptoms. So a person who wants to be on Vivitrol either has to be completely off opiates and probably in recovery for quite a while, and actually really motivated to work on changing lifestyle habits and getting jobs and getting back to life, because your cravings and the drive to do drugs doesn't get squashed by the Vivitrol. So what we kind of look at is the Vivitrol is sort of like a graduation drug. It's really motivating for people who are coming out of jail who have not used drugs for the entire time they're in. It's an excellent choice. A lot of the jails now are actually giving patients a shot before they actually come out of jail. So they've already had one dose. And so hopefully our community health centers are now grabbing those patients and continuing treatment and helping those inmates, now parolees, stay clean. Then there are a lot of other patients who are your doctors and lawyers and police officers. They're highly motivated. They have working in the community already. Those patients are your good candidates for Vivitrol. There are a lot of people using Vivitrol out there straight out of treatment. They do tend to struggle a little bit, but their choice is to be abstinent, and that's the other side of the coin, is to either take medication that is your substitution drug or to be abstinent. And it takes a lot more motivation, but we do encourage patients to choose the pathway that they feel they're ready for.
You keep referring to different types of patients. So can you tell us a little bit about who is the best candidate for office-based opioid treatment?
So certainly a patient who's had a history of problems with opiates, and that can be a person who's had a problem with pills or a problem with heroin. And I don't know that there's actually a best candidate. I don't know that there's too many people that we would say no to that need help. A person that wants to be in our treatment has to be a person who's ready to actually have treatment, and that's really the key deciding factor. Are you ready for treatment? You can't just be expecting a medication. That's when it becomes just a substitution. What we don't do is just hand out pills. We are working on helping people change what it is they were doing before they came to us, by learning how to eat better, learning how to sleep better, connecting them to behavioral health to deal with the emotional stressors that are going on in their lives.